So if I can perhaps more formally welcome you. I'm Keith Pearson, and I really would like to extend a very warm welcome to all of you to this really quite important event. I know that many of you have travelled some distance. I think some of you will have been caught up in the problems that there have been on the tubes today. But I just wanted to say a huge thanks for taking the time to come here to join HEE for our celebration of NHS 70. I'll be your chair for today and throughout the whole of today's proceedings. But I have to start, if I might, by just saying that I owe a huge debt of gratitude to my HEE comms people who have put this event on today and have brought everything together to make this happen. Just some technical things. If there is a fire alarm, will you please follow the fire exit signs from this auditorium and out through the venue itself. You'll see that Wi-Fi is available to get delegates, and the password is shown here. So as I open this event, let me remind ourselves that HEE exists for one reason and one reason only, and that is to improve the quality of care delivered to patients through focusing on education, training, development and workforce transformation, underpinned by the values set out in the NHS Constitution. As we gather here today, more than 160,000 students are at this very moment studying to be part of the NHS future workforce. That includes nurses, doctors, midwives, paramedics, health scientists, dentists, physiotherapists, and many, many more roles. In fact, there are over 300 different types of roles performed by more than 1 million people in our NHS in England today. And I'd like to give a special mention, if I can, to all the students and trainees that are in the room today. You really are the future of the NHS. You've already demonstrated the NHS Constitution's most important values to get this far: a commitment to care of others and their dignity, care, compassion, respect, openness, and patient-centeredness. I'd like to thank you for choosing a career in healthcare and congratulate you for getting to where you are on your educational journey. And as we look forward to celebrating NHS 70, we know that we face an enormous education and training challenge for the whole clinical and non-clinical workforce. It is HEE's responsibility to ensure our people are properly prepared to work effectively in a changing healthcare world. A world where technology is augmenting clinical roles, where genomics and other developments such as artificial intelligence will become mainstream and a key part of the future NHS, but also a world where our people will continue to remain central to the care the NHS provides to our nation. Just 6 months ago, we published our draft workforce strategy, which took an uncompromising look at the challenges faced by health and healthcare system, charting the growth in the NHS workforce over the last 5 years, while setting out the critical workforce challenges that we will be facing over the next decade. A future in which we will continue to harness new technology, new treatments, and new ways of working to ensure patients continue to get an NHS that the Commonwealth Fund has once again crowned the best in the world. Development of the final workforce strategy is now underway, and we're working with our colleagues across the whole of the NHS to get this published in the coming months. None of us knows what the NHS will look like in 25 or 50 years' time. But what we do know is that we need to develop people and systems that are responsive to change. The trick is to have new and enthusiastic staff who are willing to adapt to change and embrace new technology. The challenge we need in our NHS going forward is for people like you, the students and trainees that are in our audience today, and your commitment to the NHS as it remains the service that people are so proud of today, and yet as it moves into that cutting edge scientific future that it will inhabit going forward. Much has changed since the NHS was founded 70 years ago, but the dedication and commitment of NHS staff has remained the defining feature throughout. And so to all the students and trainees in the room, remember that the NHS Constitution's values are absolutely integral to maintaining a positive and caring culture of care in our NHS. So over the next few hours, we will cover a range of topics from how we're preparing the NHS workforce for the digital future, the leadership within the NHS, and apprenticeships. But as I draw my opening remarks to a close, we must remember that our event today forms part of the nation's celebration of the NHS, 70 years on from its creation. On the 5th of July 1948, Sylvia Beckingham was admitted into hospital in Manchester to be treated for a liver condition. Doubtless this was a big event in her life, but it was an even bigger event in British history. Sylvia, who was 13 at the time, was the first patient to be treated free at the point of use on the NHS. The idea of uniting all of the country's hospitals and doctors' surgeries into one great state-run national health service was germinated during the Second World War. Then, Britain's 2,700 hospitals were run either by charities or by local councils. The only people who were able to access healthcare were those who had the means to pay. Many were members of healthcare provident funds who would pay for the treatment for those who could afford to pay for those premiums. Those who couldn't afford relied upon the goodwill of the professions themselves and on local safety net provision. And so it's not hard to imagine why the nation embraced the post-war NHS and why the NHS has become so central to our British way of life. Having worked in the healthcare sector myself for more than 40 years, I know of no country where its health service is so woven into the fabric of its society. Who would have thought that in 2012, a nation's healthcare system would take pride of place at the opening ceremony of an Olympics? And yet the NHS did. In 2009, the NHS tried to capture the pride of the nation by creating the NHS Constitution. The opening paragraph resonates as much today as it did then. And for those of you in the audience who have not heard these inspiring words, let me, if I can, just read them to you. It starts by saying the NHS belongs to the people. It's there to improve our health and well-being, supporting us to keep mentally and physically well, to get better when we are ill, and when we cannot fully recover, to stay as well as we can for the rest of our lives. It works at the limits of science, bringing the highest levels of human knowledge and skill to save lives and improve health. It touches our lives at times of basic human need, when care and compassion are what matter most. The NHS is founded on a common set of principles and values that bind together the communities and people it serves, patients and the public, and the staff who work for it. A very powerful set of words, and for those of you who are in the early phases of your careers, I would suggest to you that you always keep somewhere near to you the NHS Constitution. So as I move on, please can I ask you to get involved in the conversations throughout today by tweeting, those of you who do these things, on hashtag HEE NHS 70. And so I'm now delighted to welcome on stage Professor Ian Cumming, HEE's Chief Executive, who will outline the important role education and training play in delivering the healthcare of today and tomorrow. And at the end of this session, time permitting, he will also take a few questions. So if I can hand over to the boss.
Thank you, Sir Keith, and thank you to everybody for joining us today. When we were putting this conference together, we had quite a debate about who we wanted in the audience. And to be honest, we started with the default position of, and I mean this term affectionately, the usual suspects. So, you know, the college presidents, other arm's length body leaders, NHS chief executives, directors of nursing, medical directors, etc. And then we decided, you know what? We're not going to do that. That HEE's role is about the future. Our job is to make sure that we educate, train and develop people to be fit for the future. Therefore, more than 70% of people who were invited today are students and trainees. So we have A-level students, we have people on undergraduate courses, we have people studying at postgraduate level, and that's both clinical and non-clinical. So everybody is very warmly welcome, and I really look forward during the course of the day to getting into a discussion and a debate, perhaps a slightly different discussion and a debate from those that we've had previously. So, HEE is about the future. There's no point in HEE focusing on healthcare as it is delivered now, unless it's to reflect on what's good about it and what we may need to change. Somebody who starts medical school this year will become a consultant in about 13 years' time. So we need to focus on what happens in the future. But to inform the future, we also need to focus on the past so we can learn from the past. But before I start talking about what we can learn from the past and what we need to change for the future, I just want to set the tone for this by just reflecting for a few moments about what the NHS actually delivers to people in this country day in, day out, as a fully comprehensive healthcare service free at the point of need. If I could show the video, please. The people. The NHS isn't perfect, but do you know what? The NHS is full of pretty amazing people doing a pretty amazing job. And we should just take a moment to reflect on that whilst focusing on what we could do better and how we could get it right. Looking back, we've come a long way. I've got a job description from a student nurse from about 130 years ago. There is no truth that this is Sir Stephen Moss's job description, by the way. In addition to caring for your 50 patients, each nurse will follow these regulations. You must daily sweep and mop the floors of your ward, including dusting the patient's furniture and windowsills. You must maintain an even temperature in your ward at all times and bring in scuttles of coal when necessary. Light is important to observe patients. Therefore, your duties including filling kerosene lamps, cleaning chimneys and trimming wicks. The nurse's notes are critical to your physician's work. Make your notes clearly, and you may whittle the nibs to your own preference. Every nurse on duty will report daily at 7 a.m. You may not leave before 8 p.m, except on the Sabbath, when you may have a break between 12 and 2. Graduate nurses who are in good standing with the Director of Nursing will be given an evening off each week for courting purposes, or, if you go regularly to church, 2 evenings a week. Each nurse shall lay aside from every payday a goodly sum, brackets half, of her earnings for her benefits during her declining years, so she will not become a burden on others. My favourite. Any nurse who smokes, uses liquor in any form, gets her hair done at a beauty shop, or frequents dance halls will give matron good reason to suspect her worth, integrity and values. And a nurse who performs her labours and serves her patients and doctors faithfully and without fault for a period of 5 years will be given an increase by the hospital administration of threepence per day. So, have we moved on? In some ways, not really, absolutely. So, who is the NHS? Who delivers care in this country? I think for the last however long, we've focused on the 1.4 million people that the NHS employ, but that's only part of the story. Because in addition to the 1.4 million people that the NHS employs, we have 1.5 million people employed in social care. We have 5.5 million people in this country who are unpaid carers. We have 3 million people in this country who volunteer in one way or another to help people with their own care needs. And we have, as Sir Keith has already said, somewhere in the region of 160,000 students in training in this country. That's 11 million people, day in, day out, involved in care. That's 1 in 5 of the population. So 20% of the population of this country, day in, day out, are affecting the care that we deliver to people. So one of the things that I think we should be doing as we look to the future is not just focusing on the 1.4 million, but actually focusing on the 11 million and what can we actually do to provide the best possible care service that we can with those 11 million people. So if we could have the next slide, please. If we look for a moment at what's happened over the last 10 years, over the last 5 years on this slide, so carry on. Part of the technical gremlins we've got is that I haven't got control over the slides. If you could jump to the next slide, please. So, this is what's happened over the last 5 years. Now, if I ask people in the audience, and if I ask people in the wider NHS, they would say to me that things have got worse over the last 5 years. We've got fewer staff than we ever had before. Our staff are working under much greater pressure, and things are really tough out there. All of which we recognise. But do you know what? That's not correct. So Keith made reference to the draft workforce strategy earlier on, and this is produced from the introduction to the draft workforce strategy. we have 40,000 more whole-time equivalent clinicians in the NHS in 2017 than we had in 2012. 40,000 whole-time equivalent more clinicians. That's a growth of about 7.3%. In acute general elderly nursing, that's a growth of 8.6%. In emergency medicine consultants, that's a growth of about 40%. So in some areas, we have seen huge growth. However, as you'll see from this slide, in other areas, district nurses, we've seen a reduction of 26%. GPs, one of our high priority areas where we're actually trying to grow the number of GPs in this country, went down by 1% from 2012 to 2017. And learning disability nursing, down by 23%. But if the overall picture is one of growth, why does it feel so tough? Why does it feel so difficult? Well, in the same timescale as I've shown on that slide, the population of England grew by about 4%. So we've seen a 7.3% increase in clinical staff, or 4% growth in the workforce. But in 2005, the then Secretary of State for Health, Patricia Hewitt, stood on a platform and proudly told the audience that the NHS interacts with 1 million people every 36 hours. We've recalculated that for 2018. We now interact with 1 million people every 17 hours. So in that 12-year timescale, we have more than doubled the amount of interactions. So that's what we're seeing. And by the way, if we look at that nursing number, the majority of the nursing growth that we've seen there have been associated with improving the quality of care delivered to patients. We got ourselves into a terrible position around the time of the whole mid-staff scandal. What we've done since then is to invest in putting more nurses into our wards and departments. We're not where we want to be, but we've made a step in the right direction. And just to give you an example of that, one of the indicators that we use is a calculation of how many nurses we have compared to beds that have got patients in. It used to be, in 2012, 1.86, a ratio of nurses to occupied beds. It's now 2.02. So we're going in the right direction, but we're not there yet. We've got a lot further to go. What's likely to happen in the future? This slide was produced in 2015. Just focus for a moment on the green line. So the solid green line up to 2015, which is there, was the actual staff in post, registered nurses and midwives in the NHS. In 2015, some of our very clever people in HEE, led by Rob Smith, produced a projection as to what was likely to happen to the future workforce in the NHS moving forward, based on what was happening in education and training, based on what was happening in employment patterns. And Rob and his team said that this green shaded area is the number of nurses that we're likely to end up with in the NHS. Now, whenever you produce a graph like this, and whenever you show a graph like this to politicians, they focus on that line. You know, what's the best that we could possibly get out of this? You know, how can we make sure that we get this line here? The blue, by the way, is the number of funded posts. So that's the establishment in the NHS. The gap between the two is vacancies. So the gap between the solid green line and blue line is the number of vacancies that we actually have. So this is the range, and you'll see what's actually happened. And I have just seen the 2018 figure, which basically carries on right in the bottom of this shaded area. So we are within the range that we predicted, but we're not where we want to be. Why? Retention. We're not keeping people in the NHS. This is the number of nurses who left the NHS for reasons other than retirement between 2012 and 2017. In 2012, we lost, on an annual basis, about 7.3% of our nurses every year leaving the NHS, not moving between jobs in the NHS, leaving the NHS for reasons other than retirement. By the time we got to 2017, that figure was 8.7%. Now, it's quite easy to say, well, 1.4%, that doesn't sound like very much. But you know what? If we had kept at this level right the way through this period, 50% of nursing vacancies in the NHS today would not exist. That's the scale that we're actually talking about. We're now losing, for reasons other than retirement, more than 5,000 nurses a year, whole-time equivalent, than we did in 2012. We're training people, we're investing in their education and training, and then for reasons that we are only starting to understand, we are losing people at a much faster rate than we ever did before. And I want to return to that a little bit later on. So I said at the start of this talk that we needed to focus on the future, and one of the things that we're going to be doing in the workforce strategy when the final version is produced is to make some fairly robust predictions about what we think the workforce in the NHS needs to grow by through to 2027. And just to give you a headline, somewhere between 3 and 5% per year is what we believe we need to grow the workforce by to meet the demands of the population and to make sure that we provide high quality services to all. Now that might sound like a lot, but you'll be aware that NHS England have just received a funding settlement, which is on average 3.5% a year. So that's in that range. So it's not unrealistic. What we need to make sure is that we are training 3 to 5% extra people every year to allow for that growth, and that once we've trained people, we're also keeping them. So why are we losing people? And what are the drivers of change that we're likely to see over the next few years? Because one of the things we don't want to do is to train people for the NHS as it is today. Because by the time people have finished training, the NHS will have changed. So one of my favourite topics for starting a debate is to discuss radiology. If you talk to Google DeepMinds, they say that within 3 years, technology will exist that means that nobody needs to report plain film X-rays, CT scans or MRI scans, because artificial intelligence will be able to do it all. Do we believe that or not? I don't know whether it's 3 years, but at some stage in the next 10 years, yes. Of course, that is where we're going to head. So why are we still training all our radiologists to spend as much time as they are doing on reporting CT scans, MRI scans, X-rays? When do we actually change the training path because we can see a different future? Histopathology, we know that artificial intelligence, image recognition is going to change significantly one aspect of the job that histopathologists currently undertake. When do we change the training so we actually get ahead of the curve? You'll be hearing later on, briefly from me, but in more detail from Dame Sally Davis later on, about genomics. And actually, genomics is the one area where I think we've got it right. We've got ahead of the curve. But there's many others we need to focus on. In a document that we produced a couple of years ago now, called Framework 15, that took a 15-year forward look in terms of the workforce, we actually said that there were 5 drivers of change that were going to affect the workforce of the future. And those drivers of change are the demographics of the population, the impact of technology and innovation, social, political, economic and environmental factors, current and future service models, changing how we're going to deliver care, and the expectation of the population and the expectation of the workforce. Now, because I'm time constrained, I'm not going to talk through, I noticed Keith smiled then, I'm not going to talk through all of those in detail, but I just want to pick up on a few of those. And I want to start with technology and innovation. I'm not going to steal his thunder because Patrick Mitchell is going to be talking about this later on today, but I'm absolutely delighted that we are launching the interim report of Eric Topol's review into the impact of technology on the future healthcare workforce. Please have a look at it, particularly those of you who are students and trainees, because this is your future. What is the impact going to be around artificial intelligence, around genomics, around robotics? It's going to be huge. And Eric Topol, who is an absolutely fascinating guy, one of the outstanding leaders in this area. And if anyone's interested, his book entitled Doctor, the Patient Will See You Now is a very, very, very good read. And I would really strongly advise people to have a think about reading that. But he's been leading this review for us and has pulled together a team of some of the best brains in the world to try and advise us on how we need to change education and training for the future. But I'll leave that to Patrick to say a little bit more about later on. I've already mentioned money. I've mentioned the settlement to NHS England, which in the current economic climates was a fantastic settlement. So huge credit to all the people that actually were involved in getting that settlement. Our attention is now turned to making sure that education and training and the Public Health England budget gets a similar level of uplift as we prepare our cases and our debates and our arguments going through to the budget. Because if we're going to be investing 3.5% on average over the next few years in delivering healthcare, we need to make sure we've got the workforce to be able to do it. But money is tight. If you look around the world, we see people who are rationing state-funded healthcare. That's not a direction we want to go in. I think Greece is probably the most notable example in Europe, where elective orthopaedics is no longer available on their state-funded healthcare system. We've seen some countries that have gone down the co-payment route. Australia are experimenting with this at the moment in terms of co-payment to see a GP. How many people would that deter from going to see the GP who we actually need to see? And we know that one of the problems in this country is with late presentation. So that's not a route that we want to go down. Some countries have looked at constraining input costs. The Republic of Ireland, actually 2009, 2010, at the height of the global economic downturn, actually reduced the pay of people in their National Health Service by 5% on 2 consecutive years. People left. So, that doesn't work. So if we can't reduce input costs, if we can't and don't want to introduce rationing, and if we can't and don't want to introduce co-payment, we have got to focus on how we get the best possible value for money for every pound we spend. One of the privileges I have in my job is that I get to travel around the country. I see fantastic practice in pockets, in silos. If only we could bottle the best practice that we've got in this country and apply it everywhere, we have got this cracked. And that has to be part of our responsibility with education and training. From a good idea, a good concept, a proven concept in clinical care, to that concept actually being used across the whole of our healthcare system takes about 15 years. That's not just a UK figure, it's exactly the same in the States. So it's not an NHS phenomenon, it's a resistance to change, it's a how do we introduce change methodology that's causing us some of those issues. Because there is not going to be an unlimited pot of money available for the NHS. Population is growing. With thanks to Public Health England, some of the demographics there about the UK population is expected to grow to 68 million from 2012 to 2022. That's about 7%. Actually, we're ahead of that already. So the population is growing quickly. There are currently 1.5 million people with long-term conditions who account for 70% of the entire spend of the NHS. What are we doing to focus on the prevention agenda? What are we seriously doing to focus on people, helping people to understand the impact that their lifestyle may have on their health in the future? By 2037, we will have 3.6 million people aged over 85 in this country. Public Health England tell me that the first person in this country to live to 150 years old has been born. Now, apart from the economics of this, which is that that individual will spend more time out of work than in work, we have to start thinking about what are the health needs of somebody in their 120s, 130s, 100 in their 40s. By the way, I so hope that's not me. But we really have to focus on how we actually meet the needs of the population. A third of babies born in 2018 will see their 100th birthday. Genomics. I'm not going to say much about this because Dame Sally has this as a key part of her presentation later on. This is a game changer. This is absolutely fundamental. This is going to change the practice of medicine, the practice of healthcare more radically than anything I've seen in my career in the NHS. And I was reflecting earlier on, I remember the 40th, 50th, 60th, and now 70th. I'm obviously getting old. But this is going to change how we practice healthcare beyond recognition. But it's not just how we focus on targeted medicines, precision medicines. recent paper, acute myeloid leukemia used to be considered to be one disease, one condition. As a result of genome sequencing, we now know it's 10 entirely different conditions, and we now know why chemotherapy works for some people and not for others. These are what are now becoming daily discoveries in terms of the practice of healthcare. But we have to think about the ethics of it. Some of you may have heard me say this before. 1 in 10 of people in this room, your dad isn't who you think it is. We know that from existing tests that we're actually doing, genetic tests that we're actually doing. We don't tell people at the moment. It's an incidental finding. So, you know, we just say, no, you haven't inherited that disease. Not, by the way, he's not your dad. But if we get to the situation which people are predicting, and you may wish to ask Sally about this afternoon, but if we get to the situation that people are predicting, where we are whole genome sequencing the entire population of the country, moving towards a prediction and prevention, is it appropriate for the state, brackets NHS, to know something about you you don't know about yourself? I don't think it is. What's it going to do to families? Also, if we are starting to whole genome sequence and we're identifying people at increased risk of breast cancer, let's say, when do we tell them? When they're 12, 16, 18, 21? What happens if they don't want to know? So I think the whole ethical debate about genomics, as well as the advances that it actually gives us in terms of treatment, is a big, big, big area for the future. Not as big as this one. Informatics. Lady in the middle there is using her iPad from hospital to keep in touch with her grandchildren and her other family and friends. She's using FaceTime to do that, and is completely literate. She's also, as the consultant cardiologist who took this photograph said, using it to Google everything that she is told whilst in hospital. And as he also pointed out, that she asked him the most complicated question he'd ever been asked by a patient in his life about the pharmacology of a particular drug that he was prescribing for her. She's a retired professor of chemistry who now has access to information and is therefore changing the dialogue between patients. The thing on the left is the health booth. You go in, you sit down, you're having a video conference consultation with a healthcare professional who, by the way, could be anywhere in the world, globalization of healthcare. If you need a consultation with, let's pick one, an orthopedic surgeon, you put through real-time consultation with an orthopedic surgeon. If at the end of your consultation you need a prescription, the actual medication pops out of a slot in front of you because there's a dispensing robot behind it. They're building a laboratory module to go on the side of it. You rest your hand on a pad. It takes a small sample of blood and runs a series of laboratory tests through it. The chair you're sitting in is weighing you. Sensors are measuring your blood pressure, your heart rate, your temperature, your respiration. It's all running through a computer algorithm. That is not science fiction. These exist, and Walmart are currently looking at installing them in the States in all their stores. How is that going to change how we practice medicine, how we practice healthcare in this country? Just out of interest, show of hands, who would use it? Yep, so I reckon that's a good 2/3 of people. I'd use it. I'd use it tomorrow. Now, this is not about getting rid of GPs. This is not about saying we need fewer GPs. This is about getting those people who don't need to see GPs out of the GP surgeries so the GPs can spend twice as long with the people with complex long-term conditions, polypharmacy, and the people who need to see them. And we need to make sure we sell it that way. I've got 2 minutes left. So, as well as people, the people who we're treating, we need to focus on the workforce. And this is particularly relevant to many people in the room today. The NHS, at the moment, has a majority of people who are baby boomers and Generation X, who have a particular approach to work-life balance, a particular attitude that we have seen in the NHS for many years. We are now moving very quickly into millennials becoming the most significant part of the workforce. Young people, inspirational, hardworking, forward-looking, but want a different sort of work-life balance, want regular career changes, want regular career breaks, want to experience the world, want to work in different countries. How do we make sure that we have a service that is responsive to the needs of millennials and not just one that we think is right for those of us that happen to work for the NHS for the last 30 plus years? So finally, I just wanted to say something about the mix of people who we have in our workforce. We haven't got equality and diversity right in the NHS yet. Some of you will be familiar with Roger Klein's work on Snowy White Peaks, and that is absolutely correct, that the majority of senior people in the NHS are white. We need to address that. I think our Leadership Academy is doing some fantastic work in this area, but we need to do much more. We're expanding the graduate management training scheme to an interim of 500 people a year, starting on that, moving towards 1,000 over the next few years. Those will all make a huge difference to making sure that our NHS is reflective of the people we serve, and making sure that where we have got issues and challenges with the NHS, that by the time we get to NHS 80, we don't need to be talking about this, because we know that we are fully inclusive, fully reflective of the population we serve. Thank you very much indeed for listening, and if there are any questions, I'll try and take those.
I think we can probably take a couple of minutes just to take some questions. I think we'll rejig the schedule for the morning, possibly trimming a few minutes off our break. So I think it is important that you get an opportunity to ask a few questions of Ian, particularly following such a powerful and informative presentation. So, any questions from the boss? Gentleman here, what was your name, and tell us a little what you do.
My name's Tom, I'm an F1 doctor.
We've got a microphone coming on. Your name is Tom, and you're an F1 doctor.
I'm an F1 doctor from Carlisle, North Cumbria University Hospitals. You mentioned part of the problem was sort of that there's not good practice across the board. How do you reconcile that with the new model of CCGs and fragmentation within England itself? And coming from a border region, we have difficulties referring people to Scotland. I mean, it is a different system, a different country. How do you respond to those challenges of, Northumberland is just down the road, but it's different to Cumbria, and then Scotland's a whole nother beast entirely. So, what's the answer to that?
So let me deal with the easier one first, which is the England issue. So actually, I think STPs and the creation of a bigger planning population is a force for good. One of the reasons that I believe we don't disseminate best practice quickly enough is that we're not serious about giving people the time to do it. That it's almost the nose to the grindstone. Therefore, when do you actually have that time to innovate, that time to be creative? If we were a factory producing widgets and we wanted to produce a different sort of widget, you'd close the factory for a couple of weeks, you'd redesign the production line, you'd retrain everybody, you'd open up, you'd probably run at 50% capacity to test everything out, and then you'd go back to full capacity. Now, some people would say we can't do that in the NHS. I actually would dispute that, because you can do it with elective services, as long as you find a way of catching up on increasing waiting lists. But we don't invest in the education and training people. We expect them to do it in their spare time, or Saturdays or Sundays or after work. So we've got to change the culture about how we adopt practice. We've also got to get rid of the not invented here equals bad argument in the NHS. And this goes right the way back to the early 90s, when we set up NHS trusts and started competing with each other. We need to stop that competition element and start the collaboration element. So I think STPs are a force for good. I think CCGs coming together personally onto a bigger area is a force for good. It allows us to spread across that one area. It allows us to plan on the basis of a bigger population. With regard to Scotland, I can't solve that problem, but can we be clear? England can sometimes be very arrogant because we're the biggest bit of the United Kingdom. We have got an awful lot to learn from Scotland. Scotland have got an awful lot to learn from us. It isn't one-way traffic. They're doing things very differently in Scotland. Let's make sure that we learn from what's happening up there, and actually let's use the different systems as almost a real-time experiment.
Could I just, if I might, ask what your experience has been, your undergraduate experience now that you've come into the NHS? Are we looking after you?
That's a question. So I actually had 5 years out from training.
Yep.
I got very ill and felt very depressed
Okay.
first time round of F1. And coming back to it has been challenging, but actually been good. And it's particularly been good being somewhere like Cumbria because it's smaller and more kind of nurturing. I think I can see the difference between F1 in 2011 and 2017 in terms of morale and recruitment. And I think a lot of my friends who graduated then went into training, and now most of my cohort are not planning to go into training after F2. The vast majority are taking F3 years, going abroad, not locoming long term, and that seems to be quite
Can I
a
just
big
dive
thing.
in there? Because people expect us to say, oh, that's awful. That's not. That's really good. That actually we warmly welcome F3 years. We warmly welcome people planning their career in a different way. We warmly welcome people gaining experience from overseas. And the only rider I put on that is we want them to come back again. So, at the moment, roughly the same number of people leave the country every year as come back. That's what we want to continue. But the rest of it, we welcome with open arms.
Okay, I think we've managed to get the microphone through to you. Thanks for your patience there. And I think you'll probably be the last one in this session, but there'll be plenty of other opportunities for questions. Over to you, sir.
So I'm an F2 from Preston. So my question was, you mentioned about the generational gaps. When do you think the NHS will become responsive to millennials, both patients and staff? In how many years?
So very soon a report is going to be published actually by NHS Improvement ourselves and NHS England that tries to deal with this key issue of retention and basically says, how do we become a modern model employer? Now that's a bit jargonistic, but basically, how do we respond to people's needs for flexibility? How do we offer people sabbaticals in return for commitment to the organisation as a period of time? How do we... a light bulb moment, actually, a little while ago, I was talking to my opposite number from Australia, who basically said, you lot in England, all you do is nick our nurses. We train them, then they all come over here and say, you lot in Australia, all you do is nick our nurses. And then, why don't we swap? So, if our people want a year in Australia or 2 years in Australia, your people want 2 years here, why don't we manage this so that as employers we can actually coordinate it and not have a vacancy? So something in the next couple of weeks that sets the scene, that moves away from a very, very traditional model of employment that I recognised from when I started in the NHS in the 1980s, through to something that actually responds to people's needs and desires of today. First step in the next couple of weeks.
Did I hear you say you come from Preston?
Yes.
Did you say Preston?
Preston, yes.
Yes, God's country. Well done. Excellent. Splendid. Well, thank you for your question. And if I can also say a very big thanks to Ian for such an informative presentation. And thank you for our questions. Let's just take some opportunities, if we can, throughout the day to try and see if we can slot in opportunities for questions. Okay, so I'd now like to welcome onto the stage Professor Wendy Reid, Health Education England's Medical Director and Director of Education and Quality, who'll give us an insight into her own experience of training, and she will chair a panel of the Health Education England Clinical Fellows who will provide their own insight. So if I can welcome onto the stage also Paul Gilbert, who I think is a Pharmacy Fellow. Paul, well done. Laura Hales, a Nursing Fellow, and Tarima Martin, who's an Academic Clinical Lecturer in Radiology. So over to you.
Thank you very much, Keith, and thank you very much for your opening remarks. It's always hard following Ian, but I see he's left the room, so that's fine with me. So why are we having a clinical fellow session? Well, we thought we really wanted to hear some of the voices of the future, but I can't resist the opportunity to look back just a little bit. And in the context of a 70th birthday, for those of us that are having big round number birthdays coming up all too frequently, I wanted to have a little think about where I'd come from and what my recollections of the NHS were. This chap was Prime Minister when I was born. For those of you who don't know, it's Harold Macmillan. And since that time, I was born within the first decade of the NHS. We've had 12 Prime Ministers. We've actually had 24 Ministers of Health, now called Secretaries of State for Health. And the longest serving one is our present one. But I'll give a prize to anyone that can find me a photograph of the Minister of Health when I was born, because his name was Dennis Vosper. So not always a high-profile job, I think. However, I decided fairly early on that I had the technical skills to follow a surgical career. I don't think any of my patients are here today. However, I was lucky. I went to a school where it was an all-girls school. There was no doubt we had a rigorous academic upbringing. My headmistress had a double first from Cambridge in physics and maths. And I didn't know that there was any difference in my aspirations to anyone else. But at this time, if you were a nurse, you couldn't be married and work. I didn't know anybody that was a woman as a doctor. My GP was a man. My dad was a psyche hospital chaplain, and all the consultants were men. But somehow, I just wanted to be a doctor, and I had the support necessary to make it. I went to the Royal Free, which is a women's medical school, but since 1952 has taken 50% men. It took another London medical school another 25 years to gain parity. So within my lifetime, we've only had 50-50 women and men at medical school. I was unusual because I got married as a medical student, and I actually had to ask permission to get married from the dean of the medical school. He told me I was a fool, that my husband was a waste of space, and that my chosen career of obstetrics and gynecology would be a disaster. I have to say, he was reasonable enough when I got my consultant post at my own hospital as a young consultant. He wrote to me and said, "Congratulations, and I believe you're still married. Well done." But this is what I was seeing. These wonderful old films, James Robinson, Justice, Doctor in the House stuff. I don't see me or anything like me represented there. Role models aren't always what we expect them to be. It is interesting that the only woman is the one in bed, scantily clad, but she is actually smoking, which I think is quite cool. And when I was at medical school, we were obsessed with MASH. It's endless reruns on television. But again, there was nobody that looked like me there. I mean, I quite like the look of Alan Alda, as I'm sure many of my generation did. But the only nurse was the butt of jokes, and the teamwork only came through when the doctors chose it to come through. And that didn't feel right to me. And a book that was published during my time at medical school by Samuel Shem was The House of God. And that was the first time I'd ever read about how to work as a doctor in a team. It's a really great book, even now, slightly old-fashioned, but it taught me something about myself that I think helped me in my early days as a young doctor. And I chose to do obstetrics and gynecology. Just to show you that this is what my family think I do now, lecture them as much as anybody else. But I was lucky in that I got an early interest in education when it was the Cinderella of anything in medicine. And I was fortunate again, and the first time I ever worked for a woman was when I'd been a consultant for 5 years already. So my first and only female boss was when I became a postgraduate dean in London. So that, I think, is changing, but it's very slow, and I think it's not just up to the future generations to push for change. We all have to. So in the interest of today, I was thinking about, my colleagues, and this is the wonderful Lisa Bayliss-Pratt, who's our nurse director. And this is Lisa in 1996. I had been a consultant 2 years by then, but this is her graduating. So we embrace youth at our executive team. And this is Lisa now. And I got to thinking about what questions am I going to ask our colleagues. And I think it'd be really interesting to try and think about the next big anniversary, the 100th anniversary of the NHS, what will we all be doing? And so, obviously now with the technology that we have available, we can look into the future. And we all know that people like Lisa will be ever glamorous, continuing to live a full and active life at a very fast speed. However, when you come to people like myself, we might have a slightly different future. And many of you know that I have an obsession with one day sitting under a tree in Italy. And I hope still to be around in 30 years, and I hope that the generations here are getting ready to look after me, because this is what I think I will be doing on the 100th anniversary of the NHS. So, without further ado, if we could just bring the lights up, I'd like to introduce our clinical fellows. And please can you take that photograph off, because it is quite scary. Get the clinical fellows to each introduce themselves, say a little bit about their backgrounds and what they're doing now, and then we'll pause, move on to the next one, and then we'll come back to the where do you think the NHS is going over the next 30 years. So, Tarima, would you like to introduce yourself?
So good morning, everyone. I'm Tarima Mattin. This year I'm doing a clinical leadership fellow at Health Education England. So I've taken a year out of training. My background is as an academic clinical lecturer in radiology at Oxford. So I'm quite towards the end of my training with only 4 months to go. And a lot of people ask me, why did I decide to take time out when I'm so close to the end of going along that conveyor belt? And really, I got to a stage, I think, during my training where I was doing lots of research. It was very interesting. My clinical practice was also going well. But I felt like I couldn't really impact a lot of change and potentially had more to do, but I needed some skills, so in management and leadership, to do that. And that's why I took the year out. And hopefully, this is sort of the beginning of my leadership journey, and yeah, let's see what happens.
So when you made the decision to take the year out, did you discuss it with anyone? Did it feel dangerous? Did it feel something risky to do?
Yes, massively risky. So that's a common theme that's sort of throughout my career. I've always tried to avoid the obvious choice or the kind of safe option. I don't know whether I'm trying to be a little bit different or independent, but just make my own path. So I was discouraged actually to take this year out because, what a whole year away from clinical practice, how will you be able to get back in touch? But I sort of thought, well, I've had 3 years out to do a DPhil. I managed absolutely fine. I'll just throw myself back into it and pick it up. So yeah, risky, but the reward is so much more than the risk that I think that's why.
So what have you enjoyed most about your last year then? And you've got to say working with me.
Obviously. Definitely just having that headspace. So I feel a bit human again, not doing night shifts and weekends. Being able to sleep properly, eat properly, do a bit of exercise. But just to think about myself and where I'd like to be, that opportunity's been brilliant. The networking opportunities, so meeting so many high-profile individuals and trying to just pick their brains of, what are the pitfalls to avoid, and, how do you create opportunities for yourself. So yeah, and also being involved in high-profile national projects, so learning about health policy and politics.
Thanks, Tarima, well done. We'll move next to Paul, I think, because you're still in the fellowship. So, Paul, do you want to introduce yourself, say what you do now?
Hello, everyone. Thank you very much for the invitation today to come to the Royal Society of Medicine, which, as a pharmacist, does make me feel slightly imposter-like. But thank you very much, and everyone's been very welcoming. 14 months ago, I was a pharmacist on the shop floor of Morrison's in Coventry. If you said to me then, I will be here today, I wouldn't have believed you. So I think being here today is a powerful statement about what the opportunities of being a clinical fellow can provide. I love Morrison's. It was a gritty northern grocer. It was hard work. There was hustle and bustle, and there was pressure to deliver. But that, truthfully, is a culture and environment I think everybody probably can relate to. I took an opportunity. I wasn't sure I could do it, but I'm here today, and I'm so glad I took that opportunity. And to trainees, and also to senior leaders as well, I would say, take those opportunities when they present. You don't know when they're going to, where they'll lead. I've had a fantastic experience as a fellow working for HEE. I moved from community pharmacy into general practice as a pharmacist, clinical pharmacist in general practice role. It's been an absolute eye-opener, and I've loved every minute.
So how did you get into pharmacy in the first place, Paul?
Well, that journey started way many years ago when I believe I was in year 10 and we had to arrange some work experience. And I thought, well, I like science, I like people, maybe healthcare's for me. I had very little contact with healthcare. I've been quite a healthy individual. A few rugby injuries, although I think they came later than that, the big ones. So where can I go? And the big brand on the high street is Boots. So I walked into Boots and I asked the pharmacist if I could spend, I think it was 4 days we had to arrange. And he said, yeah. I couldn't believe my luck. I was lucky. And it's been great to participate in my GP practice with the HEE work experience program. And, I think as leaders, we need to provide opportunities for people to come and experience healthcare. And I loved the time in Boots, and I loved the hustle and bustle, and I loved community pharmacy, and I still do in a way, and it'll always be part of me.
Well done, Paul. Laura, you're next.
So my name's Laura Hales. I work for the Academic Health Science Network in the East Midlands and part of the Patient Safety Collaborative. So I'm a nurse by background, and whilst you don't need to be a nurse to do my role, it helps. And I think just to have that understanding of healthcare, and to also have that badge, the physical and the sort of metaphorical badge, to go in and to say, I understand what it's like. So I suppose a bit about why I became a nurse. When I was growing up, my auntie was a student nurse, and she was in London, and she was having a fantastic time. And I thought, she's really cool. I want to be cool. I think if you're a nurse, you'll be cool. So, not too sure that was right. But she was using this. She went to Australia when I was about 5, and she brought us back loads of things, and she'd been to Thailand and she's seen elephants. But she was doing that because of her career, because she could travel around and use that. And I thought, okay, that's great. And then as I got a little bit older, so I was a couple of years after that, she came out of the NHS but went in to be an occupational health nurse and worked for McVitie's. And I genuinely thought if you were a nurse, you got paid in Jaffa Cakes.
Clearly we've missed an opportunity there.
So, yeah. So that's why I became a nurse. And I thought, actually, I better give this a go and see what it's like. And did lots of different opportunities all through growing up, being a Red Cross cadet and things like that. I thought, yeah, this is for me.
So what made you step into your role that you're in now? Because that's quite a challenging role.
So I'd say I've had an unorthodox career. But I think there's lots of us out there, and I think there's more of us out there. So I started off in Nottingham, so I work across the East Midlands. I went to Nottingham because it's a great university. It was one of the top places to go to do nursing. And I wanted to stay in Nottingham because that's where I'd learn. I'm from Bedfordshire originally, and I thought, I know the paperwork, I know the things. Get your head down for a year, get to grips with that, and then go travelling and do all that. 18 months into that, I was on rotation. I was adult nurse working in oncology. I saw a poster in the staff room when I was on a long day, and it said, would you like to go travelling for 3 months around America, investigate a work project and get paid? And I thought, to use the American phrase, that's a no-brainer.
Good for you.
So I went out there to have a look at something called shared governance. That's a bottom-up way of doing their management with nurses. I got to see a lot at a very early age. Came back and implemented that across Nottingham University hospitals and got to work in a corporate nursing department and nursing development, and saw a world outside my bubble and a world outside my little ward.
So 3 very different experiences of young people all contributing massively to the care of patients, but also, it seems to me, having some fun. And I think there's a huge message that we need to send to our colleagues that no matter how bad it is, most of us wouldn't change our jobs. So now I'm going to ask you how you're going to prepare yourselves for looking after me as an old lady. So let's start with you, Laura. What do you think you're going to be doing in 30 years' time in the NHS?
I don't know. I'll be very honest. I don't know if I'll be here. And that makes me quite teary, actually.
Okay.
I think we drastically need to rethink our nursing retention strategy.
Yep.
I don't know. If things stay as they are, there's not a space for me.
Okay, so that's a really powerful message that all the things we're trying to do to change, to individualise career pathways, to be flexible and embrace diversity in its true sense, that would work for you.
Absolutely. The will is there.
So when everybody's here in 30 years' time at the 100th anniversary, Laura will be giving the keynote. Okay.
Yeah.
Paul, what do you think over the next 30 years? How do you see your career?
Again, like Laura, I think it's very, very hard to tell the future direction of where we'll be, but I know that when I see an opportunity, I'll probably try and take it. I think that certainly medicine will become more personalised, and I think that will create a demand and roles for pharmacists. I certainly like to personalise my approach to prescribing and medicine now, and I think that personalised approach with genomics and the future's changes in technology will only become more. So I think I'll probably be delivering very personalised medicine, I hope.
Excellent, thank you. Terima?
So I also don't think I really have a clue really as to what I'll be doing in 30 years' time, but I'm quite excited about that. I feel, particularly after this year, quite comfortable in the ambiguity. Certainly technological and scientific advance, as you mentioned, Ian, is now overtaking our capacity to keep up with it. So we are going to have to change and think about how we adapt to practicing medicine. And as a radiologist with artificial intelligence, I look forward to embracing that change and thinking about new ways of practicing medicine.
So thank you. I think some really interesting comments, some challenges for those of us that are leaders of the system. But I think I feel very secure in my future healthcare needs if we've got people of the sort of authenticity and integrity of our three fellows. So thank you very much.
You've met three of the clinical fellows. There are other clinical fellows in the audience, and they've been very modest in what they've said. There are two very pivotal reports coming out. One you're going to hear a bit more about later, the Topol review, in which the clinical fellows have played a very, very important part. In the commission that I'm doing, much of the work has been led by the clinical fellows. Their fingerprints are all over those reports that we are about to provide, and they will be able to take what's coming through in those reviews and reports into their futures and into the future NHS. So thank you again, and thank you, Wendy, for leading this. Thanks very much. It is rumoured we're going to let you out of this room for a very, very short time. And the deal is this, that if we let you out, we do want you to come back. So I think we're going to take about a 20-minute break. If you go out into the Cavendish room, there'll be refreshments, etc. there. And then the next session will start in here. So again, thanks very much, and do have a few minutes to look around and a little bit of networking as well. Thank you.